For the final video of this elbow series, I suppose you'd call it, we are just going to touch on elbow fractures and a specific focus on how I would like for people to think about these with regards to the pathoanatomy that we've touched on a lot of the stability side of things, and then your rationale as to how you're proceeding through, how you would explain how you manage these cases if you were in theatre. The concept of talking about a fracture is we will always go through the mechanism of injury, our ATLS stuff, and then our x-rays and how we would assess them. But the next level that I feel people certainly fall at would be actually articulating what they're going to do in theatre, their stages of approaches, and let's say what steps they're going to do first. Do they go medial to lateral, lateral to medial, superior to inferior? How do you reduce certain fragments? How do you approach, let's say, a medial posteromedial approach in a trimalleolar ankle fracture? So with regards to that, then in the elbow fracture side, we are going to touch back onto what I've been harping on about, which is know the anatomy and the pathoanatomy, and specifically understanding the subcategorizations of the coronoid fractures, the radial head fractures / interradial neck, which we've touched on the stability side as well, and also then in coming down onto how you would link all of these together to bring you into the terrible triad fracture. So the way that I've learned these is increasing steps of complexity based on the actual fracture patterns, and then putting them all together for the terrible triad, and that kind of Venn diagram that you might have in your head of the coronoid fractures, the radial head fractures, and the dislocation, what they all mean when you've put them all together. The other thing that I've taken from a number of books recently would be begin with the end in mind. And what I mean by this is, what do you want to achieve at the end of your surgical intervention for a patient with a terrible triad fracture? You want to restore range of movement, you want early range of movement, and you want to restore the stability to allow that early range of movement, and then appropriate anatomical reduction with future fusion and, or rather future union of the fracture. So if that's what you need at the end, you then need to think about, how am I going to achieve that through my coronoid fracture management? How am I going to achieve that through my radial head fracture management? And how am I going to achieve that through my soft tissue stability assessment and plus or minus management as well? And this is literally the way that I've been taught to learn these and taught to, let's say, manage these as well. If you think about the coronoid process, and it's something that, again, it's only been, I suppose, cemented in my mind recently as to the actual overall anatomy of this, and therefore the subsequent pathoanatomy. We've touched on this in a few of the other slides, so not to flog a dead horse too much, but it's intra-articular and it prevents posterior dislocation. So therefore the most important part is your coronoid itself. The tip is not avulsed, but you can have an avulsion if the brachialis pulls it off down here, and then you would have a very broad-based coronoid fracture in that case. The other very important part is number 8 over here, which is the sublime tubercle, under which the ulnar nerve will run. But more importantly for this particular concept is that the muckle, or the medial ulnar collateral ligament, attaches here as well. Bear in mind that the medial facet and the sublime tubercle are very close together, but they are actually distinctly different pieces of bone, and you can have isolated injuries of these. They are not synonymous, they are not interchangeable, and they don't always end up being injured together. So that's a very important part of it. The capsule attaches 6 to 8 millimeters distal, and the avulsion does not happen to the tip because nothing attaches to the tip of the coronoid. If you move down onto here then, from the classification that's been available online from the Mayo Clinic as well, and they break it down into tip fractures, anteromedial fractures, and specifically over here where you're coming down onto the tubercle versus the medial facet, and then the basal ones which come right across here as well, or directly across, involving the PRUJ. So this will be very like the Frankel classification of the distal radius, where your DRUJ is involved, and in this one your PRUJ is involved. So the reduction of this is vital, because then your supination and pronation can be affected. These are things that you might not normally look for on your axial views of your coronoid and your elbow itself on your CTs, but this is very important here. And these two boys here of the medial facet and the sublime tubercle are two very different things. These will ultimately rotate into, convert into your injury pattern, and it normally is a posterolateral rotatory instability type picture, where the proximal radioulnar joint has rotated off of the humerus, and then the lateral humerus going through in that valgus force and hyperextension, the lateral condyle or the lateral epicondyle and the trochlea comes across here and rotates outwards and takes off the front of your coronoid at this point. And then if it completely pulls away, it may then take away your sublime tubercle as well. So looking at these two boys, these are distinctly different. This here can often be played down as a tip fracture, and people say, oh, it's just an avulsion, it doesn't really matter, and the stability isn't actually that important. But actually this is vital, because if you'd imagine you're coming up into deeper flexion, if this is not engaging properly in the coronoid fossa at the front of the humerus, this is a significant problem for the instability, and then you have that posterior translation and possibly that ulnohumeral sag that you're seeing as well. But finally, I've been trying to get onto this slide, obviously, subconsciously. The radial head itself, again, we've touched on it a little bit, but just remember that it's only covered 3/4 of the way around the clock in cartilage, and you have between 90 and 100 and 120 degrees that is not covered in cartilage, which is your bare area, identified by number 2 here. And again, depending on what you read, but ultimately the way that I think of it is it's a smaller area, so therefore my channel and my range for error is narrowed, and then it's more accurate. So if I go for 90 degrees, I'm safer, knowing in the back of my mind that it's probably 120, but I'm going to say 90, and then it's a safer area. The definitions then here, and interestingly, this is not the Mason classification, because the original Mason classification goes 1, 2, 3. The type 4 was brought in by Johnson, and this talks about a frank dislocation of the elbow, plus or minus any of the above as well. So it's something just to be aware of. If you do decide that you're going to start mentioning classifications, make sure you know the nuances. It's the same thing as saying that, does the Laug-Hansen classification, or the Weber classification of the ankle, does it include anything for the medial side? And actually, in fact, it does. It's just often forgotten. The Mason classification of the radial head injuries has 1, 2, and 3. It does not have number 4. This number 4 was added in by Johnson, and this is a separate thing. And it actually has appeared in some journals where they have said that the Mason 4 exists, and it doesn't. That is not correct. For the terrible triad injury, it's something that you might think, look, I'm again teaching how to suck eggs, but it's something that I think you need to be aware of being able to explain injuries if you use either eponymous descriptions of anatomical surgical approaches, the difference between a Cocker and a Kaplan. And then, for instance, as well with the terrible triad, you need to be able to remember the difference between the terrible triad and the unhappy triad. And then specifically for this, then knowing what it is and what it isn't. A terrible triad is different to a transolecranon fracture of the humerus, of the elbow, with a humeral dislocation through the ulnohumeral joint. That's a very different animal to a terrible triad, and don't just look at them as, it's a smashed elbow, they're thinking, click, terrible triad, and you launch into it. Be sure that you understand the difference between a transolecranon humeral fracture dislocation, or rather elbow dislocation with the humerus going transolecranon, versus a terrible triad. Take each section, like we've touched on, know the anatomy and the pathoanatomy, and if you know the biomechanics that we've touched on in the instability talk, you can then know the solutions and, more importantly, the order in which you are going to address these. These are very different to a simple elbow dislocation, and the reason these are so different is because the coronoid process gives you osseous stability. The radial head, or the radiocapitellar joint as well, takes 60% of the load distribution in extension in the intact elbow, and a dislocation means that your lucal has to be injured to some degree. It's the same thing as a patellofemoral dislocation of the patella sitting laterally. The MPFL has to be injured to some degree. The muckle being involved depends on the degree of distraction and how much you've seen on either a video of the injury or the initial pre-reduction x-ray, but it just depends on what you're looking at. But ultimately, a dislocation of the elbow means that you, by definition, have to have some injury to the lucal, and that's what you have to be aware of at all times. This then gives you an idea in graphic detail of the impact of a terrible triad. So you can see here the 3 components that we're talking about here. You have your soft tissue transection here for this ligament connecting to here. You have a radial head fracture, and you have a coronoid fracture as well. And it's not just the tip. This is something that can be addressed. And we often look at these and think, oh, It kind of looks like the AFL or the ATFL fracture of the ankle. It's probably going to heal. It's not really a big issue with the avulsion, but it's the significance of this from an osseous stability perspective that will make you more keen to actually go ahead and operate on these and fix the coronoid process itself. The management, as we've touched on, again, you have to get through this quite quickly because the examiners know that you're going to give the ATLS protocol, neurovascular intact, examination closed, Bose guidelines for open fractures, IV antibiotics within the appropriate time frame, gross contamination being removed, no mini washouts in ED, and we move on. Get this across quite snappy and don't waffle. You're not being intelligent if you are slowing down and people say, oh, well, if you keep talking, you can't lose points. Well, you can't gain points if all you're saying is complete rubbish as well. So make sure that you're getting your point across as to what they're asking. They're not asking you for an ATLS protocol. They're asking you for management of the elbow, and they just need you to tick the box to be safe, get it across that you're being sensible MDT approach with regards to the trauma bay. But ultimately, they want to get you into theatre and say, okay, patient's on table, stable, everything's fine. What are you going to do about addressing the instability that is now inherent with this injury of this elbow? You break it down into how you'd approach the case. The pathoanatomy of the case dictates your methods and thus your order in which you address these problems. Assume you're in theatre. They've been managed correctly. They're neurovascularly intact and they're on table safely and physiologically and hemodynamically stable. Point done, get down to business. The operative planning then talks about the issues, and the dislocation of the elbow is now end-located, so it's sorted. If it's not end-located, you have to get it relocated. If it can't be done in the ED, you talk about taking them to theatre. And then you talk about, well, if I'm taking them to theatre anyway, with what I've seen on the injury on their plain films, then you have to talk about, do I bring them in for one general anesthetic? Do I have the skill set and do I have somebody present who can do it? And if so, go ahead with the definitive management of that patient. That's purely a logistical issue of if it's 3 in the morning and you're just relocating the elbow, then that's fine. However, you could say, I need an appropriately trained or fellowship trained elbow surgeon to deal with this. However, I'm aware of the principles, and therefore the principles are. The 3 issues still remain even when you've end-located the elbow. The coronoid process fracture, the radial head/neck fracture, and the local avulsion, attenuation and sprain, plus or minus the MCL or the muckle. Now, will an EUA change this? And generally not, because you know that by definition it has to be unstable. All you're looking for then at that point is the muckle gone. There's no point in doing an EUA for the lateral side because none of your lateral structures are safe, they're not intact, and your A to P structures are not stable either. So therefore, doing an EUA at this point is unlikely to be of any use. You can address it, but be careful about mentioning it because they may then say, and I would ask you, what is it that you think you might find on an EUA that would subsequently change your management of what you've mentioned in your other 3 points and your issues that you've outlined? Think of your order in addressing these and how you'd approach it, and think about what comes first, what comes next, what has to be done before the next part, and am I burning bridges in addressing one part before I move on? The way to look at these then, in my mind, is address the medial structures first. And the reason for these then as well is that you have to get that coronoid down. And if you try to go addressing the coronoid from the lateral side, it's going to be quite difficult, and you're ultimately trying to do a lateral column approach on an already damaged lateral side. And theoretically, the medial side should be relatively virgin tissue. And your decisions here would be whether or not you're doing a medial approach with a Hotchkiss over the top, between the FCU heads, or a tailor and sham to get down to the base. Now, the big thing here is don't forget your ulnar nerve, and don't forget the MCL or the MUCL. If you haven't seen your ulnar nerve on your approach, doing a Hotchkiss approach is a little bit dangerous because you're going to be putting your mini Homans in and then leaning downwards on this and possibly tractioning the ulnar nerve that is already likely to be injured due to the injury. So therefore, what we would be taught, where I'm currently being trained, is that you should consider doing the split between the 2 heads of FCU, formally decompressing the ulnar nerve, and you can see it. And then when you're putting in your retractors, everything is in front of it when you take down your anterior head of your FCU, and then you're protecting the ulnar nerve behind it by leaning on it with that. You're not directly leaning on something that's blind and not knowing where that ulnar nerve is sitting. So it's something to keep in mind. If you're getting into this point, it's something that you will then have been discussing, and the examiners, and again, there's life after the exam, but the examiners will know, okay, this individual has been here, they've at least talked about it, if not done it, and they understand the issues. The other thing with going down the splitting the head of or the interval between the heads of FCU means that you are down onto the ulnar nerve. You can also then move it to look at your MUCL and look at the bands of your MCL as well to see what you are dealing with, and also being able to address those later on the way back out, and also your approach is done as it is when you want to address it. Doing the tailor and sham is probably not really required, because if you're coming down that far onto it, it's going to be a much bigger fragment and it doesn't really come off that way. And if it is that big a fragment, you're probably more likely to have had a transolecranon fracture with a humerus essentially die punching through the ulnohumeral joint. And in that case, you're very likely to be doing a universal approach from the back with the patient on the lateral position and doing a midline dorsal or extensor side approach. The olecranon osteotomy has been done for you already, and then you will be able to see the coronoid already through that elbow joint. So the chance of you having to then further insult the medial side and the flexor pronator mass of that elbow is kind of unlikely. So then the tailor and sham is more involved, even if you're approaching it from the back of the elbow here, as opposed to trying to come across it directly here. So you're looking at that side, depending on the interval is important, but the skin incision can change. So it's just good to know where the anatomical structures are. And the main point here is that your ulnar nerve is your big kind of risk area, but also can be your friend, because it gives you that nice idea of interval and where we're looking at. Looking at the coronoid fixation process, the AO website has very nice pictures that will give you an idea as to what you're doing. And you can see here that they've gone with an olecranon plate. And of course, to do this, you would have, as we've just touched on, a midline incision at the back with a single transolecranon to coronoid screw with a buttress plate here that you can see with no screw here, but two screws fixing it here. But an isolation of that one can also be used here if you're coming down onto just that more medial facet down into the sublime tubercle as well. The fracture pattern will dictate what you do, and it's exactly the same as a medial malleolar fracture. Whether you've got a vertical shear, you're going to put a buttress plate on it. You're not going to do cannulated screws because the vectors are convergent, and it will cause a shear effect of it. It's exactly the same as the coronoid. Look at the fracture in isolation. Okay, well, there's a coronoid fracture that has a broad base, and therefore I need to try to come at it at 90 degrees. Think about over here as well, though. If the tip is up here, you could direct that tip of that screw to be much longer. If the fracture fragment was coming across this way, you could redirect it down this way. And you don't need the plate to do that if this is an isolated one, and two screws or a single cannulated screw here would work very well. If you've got something that is sliding over here where you have the sublime tubercle and you're worried about that MUCL pulling on it, then putting on this buttress plate will work very well. The reason this plate has been put on is because, as we've said, we have that transolecranon type fracture, or a fracture dislocation of the elbow with this type of injury, and this has to be addressed separately. But with that then, if that was off, you could theoretically do a headless screw running from inside here across here, and it's intraosseous when this fragment is reduced and the coronoid itself is actually secured. So just looking at it, that's where I was trying to get at with the midline approach here, rather than doing that tailor and sham where you would have stripped everything off here on the kind of dorsal aspect of your flexor pronator mass. With regards to a brachialis avulsion as well, sometimes you can actually just dock this down and you can use some cannulated screws, drill bits, or purely doing it as though you're trying to do a tendon repair, but doing some transosseous tunnels and then doing a bone bridge at the bottom. Or if you feel that actually you want to go through here with a washer and a compression screw here, that also works. You can also be fancy and do it with an arthroscopic assisted approach where you're reducing your coronoid fracture, and then you're putting in a cannulated screw, and then you're running the wiring first, obviously, and then the screw over it with a headless type screw or a double pitch as well. There is no right or wrong answer. Ultimately, it's back to the same thing. Understand the fracture pathology, understand the pathoanatomy, the fragment configuration, and the main thing is that you understand when you have to and when you can repair these and when you need to address these. If you are getting into this kind of conversation in the exam, you are doing incredibly well. You deserve a pat on the back and you're doing very well, and you just need to kind of just start enjoying it and get the most out of it and try to score some extra points along the way. Now, if we come down onto the other side, imagine you've addressed your medial side, your muckle is safe, your flexor pronator mass is also safe, your ulnar nerve is happy, and your coronoid has been addressed. You now need to look at your lateral or radial side. Now remember, the radial head, again, it depends on the comminution and the level of function for the patient. The big discussion is whether or not you're going to do an ORIF or an arthroplasty/replacement. Then you could look up the concept of simple fractures or reconstructible fractures, which would lead to the ORIF. And then we talk about whether you're doing orthogonal cannulated screws or you're doing a tripod type of picture where you're trying to give that, it's almost like an inverted TP or a TP type of construct where you're trying to catch various sides of the radial head, but also involve the stronger bone and the cortical bone of the radial neck if that's not affected. If it's comminuted and displaced, you would have a very low threshold for doing a radial head replacement. The radial neck, it's a bit more of a difficult decision for the algorithm, because remember now, the radiocapitellar joint gives you 60% of load distribution in extension. This is also talking about the fact of your valgus deforming forces will try to load onto that lateral column. It has to be stable. The length of it, of that lateral column of the radiocapitellar joint and the radial neck, has to be restored as well. And you also have to respect the osseous landmarks. Now, you can consider either doing a bridge plating for secondary bone healing for a radial neck fracture, but by definition, that's incredibly precarious and has a very, very poor outcome. Lots of non-unions because we don't get the stability we need, and we're trying to rob Peter, pay Paul in keeping the range of movement of that elbow, and in doing so we're increasing the strain environment, and thus your risk of a fibrous non-union or a completely atrophic non-union is very, very high. Buttress plating can be considered depending on the fracture fragments and the fracture configuration, but it's not an inherently stable construct for the lateral column, so the rehabilitation will be impaired. And this is what I was getting at: begin with the end in mind. Can you restore their stability? Can you allow them to load appropriately through their lateral column, which is their main load-bearing column of the elbow? And if not, you really need to be thinking about, am I doing the right procedure for this patient, and am I doing this injury justice? So if you consider here, we need to consider the radial head replacement. Now for this, the reason I've put this up is actually ignoring this arrow for that coronoid tip. What I'm talking about is this sigmoid notch and also the congruent area of this joint here. This being your sigmoid notch coming across your radial head, this is where you have your level. This is where the radial head sits normally. So keep that in mind as we move on to the next few slides. The radial head replacement and the sigmoid notch on true AP is the true anatomical position. So you really should consider having X-ray in theatre for these. You will have lots of people who will suggest that you don't need X-ray because you can get the stability assessed on table. If you have osseous stability from your radial head and your radiocapitellar joint, I can tell you now that you have overstuffed that joint. The radiocapitellar joint is not inherently stable without the lucal and the RCL being reattached. You cannot be attaching, reattaching and detaching this during your time of sizing your length of your radial neck when you're doing a radial head replacement. And if we come back, this is where you need to consider this bony landmark and anatomical reference of the sigmoid notch is your landmark for it, and you need to follow that and you need to respect it. If it is, as some people will say, stable on table, I can tell you now that this is, by definition, overstuffed. It's overly lengthened, and you are going to result in radiocapitellar osteoarthritis with wear of the capitellum, and thus then losing that stability later on from that tightness, losing range of movement coming through flexion, and having a very painful pronation, supination type of picture. Here's a very good example of where that sigmoid notch sits here, but this is clearly too long. This image here, although a little bit rotated, gives you a better idea that this congruent line, you could argue maybe it's a tiny, tiny little bit too long, but it's certainly far better than this over distraction here. And by doing this, you will push them into varus. They will not be happy with you, and the pronation, supination movement will be impaired. The RF, as we've said already, is a little bit risky. You will ultimately have to take down the annular ligament and then possibly put it over the plate. As with anything, if you've got soft tissue running over a plate, then you will have some irritation during it. You will have some arthrofibrosis possibly. And also then you need to be aware that you're restoring not only the articular surface here, you're also making sure that your PRUJ is not affected. You've got appropriate pronosupination without any clicking or hitching, and you've got the length right. And on top of all this, you also then need to make sure that the length here is appropriate. You haven't engaged or you haven't actually put any metalwork in the joint, but you've also got enough stability here because you will not be able to get over to the other cortex to prevent a cantilever bending here. So you will lose the stability here, and this has to be strong enough because most of the force, as we said, 50% more force will be coming through the radiocapitellar side than the ulnohumeral side. The blood supply of the radial neck is something that has also been talked about a lot more recently. Now, this paper here goes back to 1997, but ultimately it talks about the blood supply of the radial neck, and because of this, I have a very low threshold for doing a radial head and radial neck excision and considering a radial head replacement. And the reason being, it all leads back to how likely is it that I can control their rehabilitation? How much can I trust their bone to heal? Not to mind, trust the patient themselves to be compliant, and then move on with the end in mind to a stable elbow that is not stiff and allows appropriate range of movement for function day to day. Considering your local repair, it happens from the humeral side or from the mid-substance. Now we need to then consider whether or not you're going to repair it or reconstruct it, and arbitrarily we would say 3 weeks. If you're pushing 3 weeks and a bit or up to just short of 4 weeks, then you can say, look, we'll try the repair. But you really need to be considering a reconstruction. The internal brace exists everywhere. You can do it for ACLs, MCLs, LCLs of the knee. Whether or not it's the right thing to do is still up for debate. But the big thing is you can't ignore the lucal. The lucal is really important. Now, if it comes off of the ulnar side, because of the base of the lucal's insertion on the ulnar side being so big, the chances of you needing to do anything on the ulnar side is very, very low. The CT may even show some avulsion fragments on the ulnar side, but the chances of you needing to do something is very, very low. With regards to the actual repair of it, you can look at either repairing it directly, and you can then discuss doing transosseous tunnels, doing transosseous sutures without tunnels, or simply putting in an interference screw with an anchor, or how you want to go about it. There again is very little evidence whether or not it's right or wrong, but there is ample evidence that the lucal needs to be repaired for that stability. And therefore, that is where you decide your stability. And if we bring back to what I was saying about the radial head, get your bony landmarks correct. Get your osseous landmarks with the sigmoid notch to the level of the radial head correct. And then you know that you are respecting the patient's original anatomy. The lucal is what gives you that stability after the fact. Now, the rehabilitation considerations in getting to the end of this is where it really kind of kicks in. The physiotherapist is going to ask you what the patient can and cannot do. No idea. That's the big problem. And we talk about this concept. It all comes down to what the original injury was and what you have done to them, and also how you have approached them, which is why I really want to get you to focus on the fact of doing a bridging plate, because we have this inherent fear of replacing joints in young people. But if you do a bridging plate for a radial neck fracture, you can't load them appropriately until you've got bony union. If they've got an increased strain environment, the chances of them going on to bony union at 6 weeks is much lower than you would normally expect. You slow them down, slow them down, slow them down, and next thing they're stiff, 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 and then they are not happy. They'll be very good with their range of movement if you're getting them through their radial head replacement and getting on to doing their physiotherapy for pronation and supination. But ultimately, you need to begin with the end in mind. And this is my big point of all this, to bring it back to the start. Begin with the end in mind and make sure that what you've addressed gives you the appropriate outcome for that patient. You can apply that with anything. Any case you're dealing with, electively, trauma-wise, delayed trauma, anything at all. Begin with the end in mind, and then you will be able to go through this in a very sensible fashion. What were the original issues? There was a coronoid fracture plus or minus an MCL involvement, and you may have reattached this if the sublime tubercle was off. There was a radial head/neck fracture and lucal involvement, and by definition there was an elbow dislocation as well. Then you need to think about what did you do, and this is what you're going to be thinking about when you're giving the rehabilitation protocols. You restored the primary osseous stabilizer by dealing with the coronoid fixation. Your radial head replacement gave you a stable lateral/radial column. Your radial head neck orifice, is it precariously fixed? Is it comminuted or bridged? Then it's not a stable construct. Various forces must be avoided, so therefore abduction from the side, as in lifting their arm out from their side, is contraindicated. You cannot do this because you're putting them under various stress and stretching this more. But you also can't put them under valgus stress because you're then loading onto an unstable column as well. So you're distracting in one thing, but you're compressing an inappropriately compressible area as well. The forearm being kept in pronation to increase the local stability. So then it's about the Fonzie rule of thumb, neutral, and then coming into pointing towards a stable local or pointing towards a stable muckle. And it depends on how you're going to do it. Now, if you've worried about the local, let's say if the muckle and the local are both gone, you favor pointing towards the muckle because the local is actually going to be a stronger construct, and you've seen that and you're happy with that. So you need to point towards the opposite side, and then bringing them into pronation like we looked at in the stability talk. That gives you more pronation stability in doing so. Have you done a local repair or reconstruction, and then you can do your EUA after you've actually check their stability and you've restored it? And then the capsular reattachment to the ulna, then you are less worried. Now, sometimes you will end up doing a capsular reattachment at the front with an endo button or type of construct, but ultimately this is something that you'll be less worried about because generally speaking they won't have A to P instability once you've addressed everything else. Post-op, bracing versus POP. A lot of people will say bracing them is perfectly appropriate. Some people will say they want a POP for the wound healing for the first 10 to 14 days. Overhead pronation, elbow active extension. So if we go back to that paper that I showed you in one of the other videos where we talk about active range of movement is better than passive and pronated forearm is better than supinated forearm. You avoid the upper limb abduction for 6 weeks for the local. That then allows you then to work on this in a range of movement basis, whilst also not insulting any of the things that you have stabilized as it is. Now, if you think about it, if your elbow is down in front of you, gravity is pulling your ulna down and distracting your ulnohumeral joint. So this is why we talk about the overhead pronation elbow active extension. If you look at it this way, gravity is now pulling the ulna down onto the humerus and your ulnohumeral joint is therefore stable and reduced. And that is why you would get them to do their range of movement like this so that they are in a pronated fashion with their hands to the ceiling and pushing up and down as gravity allows it. So gravity is pulling their humerus down, their ulna down onto their humerus. Their hand is in pronation, which tightens up their local reconstructed area, and their active range of movement means that their brachialis is going to be pulling their forearm into the joint, and it keeps them stable. And this is why for the first 6 weeks we do overhead pronation elbow active extension. The summary of all of this then will be begin with the end in mind. What are the issues that you've been presented with and how are you dealing with them? Understanding your osseous anatomy, understanding your ligamentous anatomy, understanding which structures are injured and which are not, and addressing them in the appropriate sequence, and then that the interventions you are putting forward and that you are performing must allow active range of movement early. It's not just active range of movement, but it's early active range of movement because you want to get them supple, you do not want them stiff, and you want to get them back to normal as quickly as possible.